My name is Irfan Aga. I'm a transplant nephrologist practicing out of Dallas, Texas. Today's session is another installment in our transatlantic collaboration with YNP. We will be reviewing a paper published in NDT titled Caffeine Consumption and Mortality in CKD, a nationally representative analysis. Before we start, some housekeeping announcements. As with our GlomCon talks, this session is CME approved, so please log in with your full name to get credit at the end of the year, and make sure you've also signed up for the GlomCon email to do so. Please mute your microphones. Obviously, you can unmute anytime to ask a question. You can also make use of the chat function to post questions. Co-moderators for the day are Dr. Jessica P. Lapacia. She's a nephrologist with the Permanente Medical Group, Kaiser Permanente Medical Center in San Francisco, and Dr. Kate Stevens, consultant nephrologist at the renal unit at the Queen Elizabeth University Hospital in Glasgow. And also we are joined by Dr. Ali Poyan Mayer, obviously the GlomCon course director, our fearless leader, and a nephrologist with the Permanente Medical Group, Kaiser Permanente Medical Center in San Francisco. We have a truly distinguished speaker and discussion panel today. Dr. Socrates Stampas is going to discuss the paper. He's a nephrology registrar with the Glasgow Renal and Transplant Unit out of the Queen Elizabeth University Hospital in Glasgow. He's also the UK national representative of YNP. We are very fortunate to have Dr. Miguel Vieira, who is a nephrologist with the Central University Hospital out of Lisbon in Portugal. He is the Portuguese representative of YNP and is also the first author on this paper, so we will hear it from the horse's mouth. And we can pepper him with any questions that we have about methodology and other details. And hopefully we'll be joined soon by Professor Cam Kalenterzadeh. He's, of course, the chief of the Division of Hypertransplant. He's a tenured pediatrics, health, and nurse out of the University of California, Irvine School of Medicine, and also is an associate editor of NDT. So this would be excellent to pose some questions to him as well. And last but not the least, we're joined with Dr. Colin Geddes, who's the consultant nephrologist and lead clinician, and is an honorary clinical associate professor with the Glasgow Renal and Transplant Unit out of the Queen Elizabeth University Hospital, Glasgow. So without further ado, I'm excited and we'll turn it over to Dr. Socrates Stampas to present the paper as I take a slug of my coffee and let him convince me that I'll live longer.
Okay. Yes. Hello, everyone. So I'm going to, I don't know if you can see the presentation.
Hang on, let me see if I can stop sharing my screen. There we go. We can see you now, so you may want to share your screen.
When I first picked up this study, I picked up because I liked the title. And then on reading the study, I thought that's a very interesting study. Though I didn't know that it actually has is the top study for altmetrics within NDT for 2019. So it has 489 altmetrics, which actually includes research blog shares, social media, and Mendeley mentions, which means that it's a really popular paper. So this was published back in September of 2018, and it talks about caffeine consumption and mortality in CKD patients. So in this slide, I just wanted to show you the content of caffeine in different beverages. So I would say that if we look at the chocolate, which stands at about in the middle of this picture, then coffee contains usually different coffee types contain more than 80 up to 150 milligrams of caffeine. I always thought that espresso is probably stronger than a filtered coffee, but it actually isn't. However, if you have a double one, then it brings that at the top. And then white, green tea, black tea, and decaffeinated coffee are between 25 and 50 milligrams of caffeine. So caffeine is the most widely used active substance in the world. For the majority of adults, consuming less than 400 milligrams of caffeine per day appears to be safe. This is between 3 or 4 cups of coffee per day. It has been shown to be associated with reduced risk of Parkinson's disease, Alzheimer's disease, alcoholic cirrhosis, type 2 diabetic gout. And it has been the association of caffeine with various types of cancers has also been investigated, but there are no associations shown. There are observational studies that show an inverse relationship between caffeine and all-cause mortality in the general population. Hence, the authors wanted to investigate if this is true for patients with CKD as well. Previous studies, a meta-analysis back from 2014 with almost 1 million participants and 120,000 deaths has shown the beneficial effect of caffeine with 16% reduced risk of all-cause mortality if someone consumes 4 cups of coffee per day. And another huge study, which was published back in 2012 in New England Journal of Medicine, including 229,000 men and 173,000 women, which were followed up for up to 13 years. And again, consuming 2 to 3 cups of coffee per day was associated with good outcomes, with a relative risk of 0.9 in men and a relative risk of 0.87 in women with regards to mortality. And this effect was consistent even for people consuming more than 6 cups of coffee per day. There are studies though that have not shown this effect. One of them was a nurse health study which was published in 2011, and it included women with previous with known cardiovascular disease, and this actually did not show any effect in caffeine consumption and all-cause or cardiovascular mortality. And there's another one which was published in 2013 with 43,000 participants, which were followed up over a period of 17 years. And this showed actually an increased mortality in people consuming of more cups of coffee per day. Moving to the study we're going to talk about, the methods the authors have used, they have actually collected data from the National Health and Nutrition Examination Survey, which is actually designed to collect data on the diet and healthy status of children and adults in the USA. And what they actually do is they do periodic interviews and also clinical examinations using a mobile center. They use data collected between 1999 and 2010, and they've been including data from 62,000 people. And the inclusion criteria were individuals that were over 18 years of age and were not pregnant. And then they narrowed that down to patients with CKD with an eGFR between 15 and 60, and a urine ACR of more than 30 milligrams of gram. Eventually they ended up with 4,863 patients because they were missing data from some of the patients. Interestingly, the authors have not included patients with CKD stage 5. So with regards to the dietary recalls, between 1999 and 2002, there was only a single 24 dietary recall collected by the patients, and after that they had access to 2 dietary recalls essentially. And based on that, they gathered all the information with regards to foods, beverages that would contain caffeine. So from 2003 and 2010, they used the mean of the nutritional information that was collected from the 2 dietary recalls. And then the participants were grouped according to the quartile of daily intake of caffeine from all the sources that were identified in the recalls. So quite a straightforward design with very well-defined and hard outcomes. The primary outcome was time to death, and the secondary outcomes was time to cardiovascular mortality and time to death by cancer. And to investigate that, they have used data linkage, is my understanding, using the from the National Death Index public access files up until 2011. So the methods they have used quite an elegant test called tailored linearized variance estimation to estimate the variance, but I think Miguel is going to describe this test more later on when we go to the discussion. They used traditional Kaplan-Meier curves and long rank test to investigate the association between caffeine consumption and time to death. And then they've used two Cox models to investigate potential variables that are associated with the outcome. And then they used a test called the likelihood ratio test for interaction. It's a hypothesis testing test to assess the extent to which CKD stage in urinaceae modified the effect of caffeine consumption mortality. And finally, sensitivity analysis, excluding patients that died during the first 12 months of follow-up. And that's because they wanted to see the longer term effect of caffeine, and then multiple imputation for missing data. So the first Cox proportional hazard model included age, gender, race, annual family income, smoking status, and then they say CKD and eGFR stage, but to me this is the same. I don't know if that's probably a typo or a comma, that apparently it's probably the same variable. And urinaceae, so essentially 7 covariates were included in the first model. And then the second model included the previous variables and some additional ones, including educational level, alcohol consumption, dietary carbohydrate consumption, the ratio of polysaturated to saturated fatty acids, dietary protein intake, dietary fiber and potassium intake, BMI, and then the presence of diabetes, hypertension, dyslipidemia, previous in mind, previous stroke. So the second model included 20 covariates. With regards to the baseline characteristics of the study participants, it appears that you can see in the columns here the different quartiles of caffeine consumption. And it appears that at baseline, people that were consuming more caffeine were more likely to be males of non-Hispanic white origin. They had a higher annual income, a higher level of education. They were current or former smokers, and they drank more alcohol, and they had less strokes in the past compared with people that didn't consume much caffeine. And then with regards to the dietary habits, they consumed less carbohydrates. They had a smaller ratio of polysaturated to saturated fatty acids. They were consuming less fibers and more potassium compared with people that didn't consume much caffeine. And then moving to the Kaplan-Meier curve, these are the different quartiles. So the first quartile included patients that consumed less than 28.2 milligrams of caffeine per day, which is potentially people that were just having a cup of tea a day or something similar, so very minimal caffeine intake. And then between 28 to 103. And then moving to Q3 and Q4, they're probably people that consume 2 or 3 coffees a day. And as you can see, quite well balanced, the numbers of the patients in the quartiles. Less people were in the fourth quartile. And as you can see here, there is a difference shown between essentially each quartile compared with the first quartile. And this difference is obvious from very, very early, and then it becomes wider with time. Within a median follow-up of 60 months, which equals to 27,700 total person years, 26% of the participants died, so essentially a fourth of participants died by the end of the follow-up. And then this is the Cox regression model, including all-cause mortality, and then cardiovascular mortality and cancer mortality. And as we can see, compared with the first quartile, each subsequent quartile, patients within each subsequent quartile had a reduced risk of mortality, and this was significant in the unadjusted model. In the first model, which included the 8 the most important variables, and then in the second model, which included 20 variables. Moving to the cardiovascular mortality, there was a signal which was not significant, though, with regards to the unadjusted model, similarly to the first model, and this was less obvious in the second model. However, this was not statistically significant. And finally, similar findings to the mortality caused by cancer, which essentially there was no evidence of any significant association. And then the investigators performed subgroup analysis. So they have split patients initially in 4 groups according to the CKD stage. So stage 1, 2, 3, and 4. As you can see, the majority of the patients included were within the first 3 stages of CKD. So eGFR was more than 30 for the majority of them, and only 179 patients had an eGFR of less than 30. And again, there was no evidence of any effect within the subgroups of CKD stage. Similarly, they have performed subgroup analysis with regards to urine albumin creatinine ratio, less than 30, 30 to 300, and more than 300. And again, there was no obvious association of alcohol consumption and mortality within these groups. These tables were presented as part of supplementary material, and they've looked separately to the source of caffeine. So caffeine association with mortality when the source is the coffee, or when it comes from tea or from soft drinks. Again, similar pattern. However, it appears that the most significant effect was from the soft drinks in the unadjusted model. But when they put all of them together, then it appears that the all-cause mortality was significant in all models. And then this is the sensitivity analysis. So after exclusion of patients that died within the first month, caffeine was associated with mortality with all-cause mortality, similarly to when we included these patients in the analysis. And for cardiovascular mortality and cancer mortality, again, there was no significant association. In conclusion, inverse association between caffeine and all-cause mortality among participants with CKD was demonstrated in this study. There was no significant association between caffeine consumption and cardiovascular or cancer mortality. And on subgroup analysis, there was no interactions between caffeine consumption quartiles and CKD stages or urine ACR categories regarding all-cause mortality. And finally, the authors conclude that caffeine consumption appears to be safe through different stages of CKD. With regards to the mechanisms, the main mechanism of action seems to be vasodilation directly in the vascular smooth cell or indirectly in the endothelial cell. So caffeine essentially does it via 2 mechanisms. It inhibits calcium channel voltage dependent calcium influx in the cell, and then it increases CMP, and this eventually ends up to a vasodilation. And then indirectly in the endothelial cell, it increases calcium channel in the endothelium, which then stimulates calcium calmodulin and eventually nitric oxide synthetase and eventually increased nitric oxide production, which causes vasodilation. Strengths of the study is obviously the large sample size with a large number of events, as we've shown about a quarter of the patients died during the follow-up. Hard outcome measures, they looked at mortality outcomes. It included patients that were not in hospital but non-institutionalized residents, and they had the full data set on the CKD stage. With regards to the limitations, the study was based on diary recalls, which may not be representative of the actual daily caffeine consumption. However, I assume that this should be very close. Causes of death, they have been misclassified. And the question is what was the most common cause of death in these patients? There might be residual confinement, which is always the case with observational studies. And finally, one of the variable that was not factored in was physical activity. This was not included in our analysis, and it's well known that people who are exerting themselves are usually having a higher caffeine consumption. And here I have put some points which would probably be interesting for discussion. First of all, it would be nice to hear more from Miguel about the statistical methods used, mostly about Taylor linearized variance estimation, the likelihood ratio test, and the multiple imputations. They have not included patients with CKD stage 5 oral dialysis, and I was wondering why. Finally, there was only 170 patients with CKD stage 4, which is only 3.7%, and the median eGFR was essentially more than 60. So if anything, these were patients with very mild CKD. And finally, it would probably be useful to have to test the caffeine consumption as a continuous variable and on top of the quartiles that have been tested. And also, the mortality rate was quite high over a median follow-up of 5 years, and I was wondering why that would be so high. How another interesting probably case for this point for discussion would be how they got access to this data, how difficult it is for investigators to use the NHA NES survey and collect this type of data. And finally, could that be that healthy individuals are more likely to select and have access to caffeine-containing beverages than those who are ill, and this could be a major confounding potential for the study. I don't have anything else, so thank you for your attention, and I would be open for comments, and yeah.
Thank you very much for that very erudite recap of the study, Dr. Stompas. That was masterfully done. I think you've come up with several intriguing and important questions. Dr. Vieira is online. So let's see what Dr. Vieira has to say in response to several of the questions that you've put forward. So Dr. Vieira, you want to take it away?
Yes, thank you. So good morning, good afternoon, and good evening, depending on where you are. First of all, I would like to thank you for choosing this manuscript and for the invitation. It's a pleasure. I would like to congratulate Socrates for the excellent presentation. And I would like to say that as a take-home message, please note that our study showed the protective effect of caffeine consumption among patients with CKD. The reduction in mortality was present even after considering other important factors, as said. And at the end, these results suggest that advising patients with CKD to drink more caffeine may reduce their mortality, and the importance of this is that this would represent a simple, clinically beneficial and inexpensive option, though these benefits should ideally be confirmed, of course, in RCT. And finally, it should be stressed that this observational study cannot prove that caffeine reduces the risk of death in patients with CKD, but suggests the possibility of such a protective effect. So in clinical practice, when CKD patients ask us if they can drink coffee, and of course this depends on the country, but for instance, in our country, in Portugal, almost everyone drinks coffee on a regular basis. Our results are reassuring that patients with CKD can consume caffeine-containing beverages. So I will try to address some of the suggested points for discussion. So beginning with the statistical methods used and talking a little bit about NHANES. So NHANES, it's from the United States. As you said, it's a periodic survey. It is conducted by the National Center for Health Statistics of the CDC, the Center for Disease Control and Prevention. And it is quite a complex survey. It is a stratified multi-stage survey, and it uses a nationally representative sample of non-institutionalized civilian population of the USA. And one interesting thing is that these data are publicly available. So if you want to have access to the data, it is possible as long as you request it and you can use it. The con is that it's not an easy data set to work with. So participants are selected at random through a complex statistical process each year, and they complete personal structured interviews at home, and then they undergo a physical examination at a mobile examination center which includes different variables such as age, weight, and laboratory measurements. So regarding the statistical methods used, the Taylor linearized variance estimation is the statistical tool which is recommended by the NHANES. So when you access the data, they also try to explain to you how to use it and which are the best statistical tools to evaluate the data. So this is the statistical tool which is recommended to perform variance estimation. And then the likelihood ratio test for interaction is the kind of statistical tool usually used to evaluate the presence or absence of an interaction. And we opted to use multiple imputation as a type of imputation method. So regarding why patients with CKD stage 5 or on dialysis were excluded, when we evaluated the patients and tried to evaluate the different stages of CKD, patients with CKD stage 5 and dialysis corresponded to a very small number of patients. And we also considered that the mechanism of action of caffeine might work differently in patients on dialysis, as these patients may behave a little bit different from patients that are not already on dialysis, and that is something that happens to different interventions. The effect of the intervention might change between patients that are still not on dialysis and patients that are already on dialysis. So regarding the few number of patients with CKD stage 4, and also the fact that the median eGFR was higher than 60 in the different quartiles of caffeine consumption, although this is a limitation, it should be noted that we used the data set that we have, so this corresponds to the prevalence of CKD in the US population. And also note that we had at the end on our final analysis almost 5,000 patients, and more than 2,000 patients had CKD stage 3. So then regarding the quartiles of caffeine consumption selected, well, the value of caffeine that defines the threshold between each quartile corresponds to the percentile 25, 50, and 75 of the population regarding caffeine consumption. And as we decided to evaluate the effect of caffeine on consumption according to different categories, we opted to divide patients according to quartiles of caffeine consumption. So then I believe that you spoke about the high mortality rate, about 26% over a median follow-up of 5 years. Again, this was the results that we had with the data set. And I think it is interesting to think that our cohort included patients with CKD, and our patients were defined with an eGFR between 15 and 60 and or an urinary albumin creatinine ratio higher than 30 milligrams per gram. So this supports the notion that we all have as a medical doctors treating patients with CKD, that CKD is associated with high mortality. So about NHANES, I've already spoken a little bit. And regarding the confounding, which might be problematic, the issue is that healthy individuals are more likely to be, well, healthy individuals could be drinking more caffeine, as sicker patients wouldn't have access to caffeine-containing beverages. So to deal with this, we performed a sensitivity analysis, and we excluded patients that have died 12 months after being included on the study. So the rationale is that doing this, we would be excluding the sicker patients, and we would no longer have this confounding, or at least it would be reduced. I think I have answered everything, but if I've missed something, please tell me and I will try to answer.
So thank you very much, Dr. Vieira, for that elaboration. You've addressed these points in your manuscript, but I think just for the sake of discussion, further elaboration, the dose of caffeine that you assumed people were taking was based on 1 or a 2 day snapshot. This is based on patient recall. Do you think this may have introduced a systemic measurement bias? Is there a statistical way in which you correct for this or safeguard against the introduction of that bias?
Well, I believe that when you use data obtained using surveys, there is always a recall bias, and maybe that's the reason why in more recent years it was possible to use the mean of the different surveys to reduce that bias. But that's something that happens every time you use a survey, I think, but it's not easy to deal with.
Very good. I believe Dr. Kalantazadeh is on line now. Sir, you're an epidemiologist, and as such, what is your critique of the design of this study? Would you have done anything differently?
Good morning. It's 8:30 a.m. here, and I've been enjoying my coffee this morning. So it's quite relevant to what I've been doing, driving and drinking coffee. And I was watching the entire presentation. So one question I have in the interest of time is if this association that was found among CKD patients, this is any different from a given association that would have been found in the same population among those who don't have CKD, and whether or not the association with survival is the same, greater, or weaker, and how this would compare. In other words, would the element of having or not having CKD play any role? Thank you.
Okay, so that's an interesting point. Before doing this study, we had read some interesting research on the effects of caffeine on mortality in the general population, and it appeared to be protective. Another interesting thing was that caffeine consumption, according to other studies, seemed to slower CKD progression, but we had at that time we had not found manuscripts evaluating the effect of caffeine consumption on mortality in patients with CKD. So that's what we tried to do, and the protective effect that we found had the same trend, so it was protective, as it had already been found in the general population. So that's correct. Maybe what we found is just the same protective effect that exists in the general population. But at least after performing this study, and of course, it has an exploratory nature, as all observational studies. I think it's reassuring that when you evaluate only patients with CKD, the same protective effect appears to exist. And then we also performed some subgroup analysis to try to look at different CKD stages and to try to look at different categories of urinary albumin to creatinine ratio categories. And there seems that there was no interaction between CKD stages and albumin to creatinine ratio. So I believe these analyses are reassuring.
There's a lot of interest on our chat channel about mechanistic what is the mechanism underlying this this effect. Are there any thoughts or theories or hypotheses about that?
So as Socrates presented, well, from what we did not evaluate what's the mechanism, but from what we the possible protective effect of coffee might be conferred by the presence of caffeine and antioxidants. And it is known that caffeine is a xanthine that increases intracellular calcium, and also stimulates the production of nitric oxide through the expression of the endothelial nitric oxide synthase enzyme. So then nitric oxide diffuses to the vascular smooth muscle cells and cause vasodilation. And it is believed that that might be one of the effects and might correspond to the biological plausibility that's important to have when you perform secondary analysis as this one. But I believe there is still lots of research being done in this area.
Dr. Geddes, let's get you in on the action. You're a fellow transplant nephrologist, and we've asked a lot of patients to drink a lot of fluids. It's interesting to note that there seems to be a stronger signal with soft drinks. How do we explain that? And is that an effect that is independent of the caffeine intake, or are there other variables at play?
So I think we have to be very cautious about the terminology we use around observational data like these. I think that we cannot use data like these to imply causation. So I don't think we can conclude that caffeine is protective. And I think we've got to look very closely at the data. And I think there are a number of factors in these data that make me very suspicious that this might be an effect of confounding rather than a direct effect of caffeine. So for example, it is plausible that your health status impacts your caffeine consumption. So certainly I've reduced my caffeine consumption in the last few years because caffeine gives me palpitations, caffeine gives me indigestion, and caffeine keeps me awake at night. It's plausible that all of these effects might be an indicator of poor health, which makes me at more risk of dying and have nothing to do with my caffeine consumption. And secondly, I think that caffeine consumption itself may be just a surrogate marker for factors that reduce your risk of dying. And in fact, there were hints of that in Miguel's analysis, that people with higher socioeconomic status had a higher caffeine consumption. And of course, having higher socioeconomic status, as indicated in this study with level of education and income, reduces your risk of dying. So it may be nothing to do with caffeine. Caffeine may just be a surrogate marker. And if caffeine is protective, why do we not see a dose-dependent effect? The top three quartiles seem to have the same impact on survival? And also, why did we not see it across all three sources of caffeine? It seemed to be restricted just to soft drinks. Were these the healthy sort of soft drinks that people who are keen on looking after themselves consume, or were they the sugary drinks that are potentially bad? I certainly wouldn't use these data to say that we should be telling patients to drink more caffeine, and I wouldn't be saying that caffeine is protective. I think it's very, very interesting.
I think all very pertinent points, Dr. Geddes. So let me pitch that question to Dr. Vieira. So patients who are in the higher caffeine group were also more likely to be non-Hispanic whites, wealthier, more educated. All of these traits are associated with better survival. Could you explain how you corrected and catered for these confounding variables?
Okay, so you raised a very important topic, and we thought about trying to introduce in our models a variable that would represent the global state of health of the patient. But unfortunately, enhanced methodology has changed over time. So although there have been questions in the survey evaluating physical activity, these questions changed over time, and there is no single question that could be used as a variable in the adjusted models, and that's the reason why we perform the sensitivity analysis. But I agree with you that it would have been important to also account for the global state of health of the patient. Another important point that you mentioned is the absence of a dose-dependent effect, and that's easy to understand on the Kaplan-Meier curves. So what we see is that when you drink, when you compare to the quartile 1, when you drink more caffeine than the quartile 1, it appears to be a protective effect, but the magnitude of the protective effect is not greater if you drink more caffeine. Well, a possible explanation, but of course it's just an explanation, is that above a certain threshold that might be deleterious, but it's just an explanation. Regarding the last question about the difference in baseline characteristics between the four quartiles, we tried to include in our models as much variables as we could.
Thank you, Dr. Vieira. So, Dr. Kalantazade, so it seems like maybe there's a signal here. How do we move this? Dr. Geddes' point was very, very pertinent. That this is an association. How do we move this to a point where we can ascertain causality?
So I think if we go over some of the features of the association, usually towards causation. That means we can never infer out of association and causality, but we can essentially we can gather a number of supporting features. For instance, if there is an association across or a gradient across association, in other words, the higher is the coffee consumption, the more protective is coffee for survival seeking patients. So that's one causation, yet still the other one is if this association has been shown in other similarly vulnerable populations, for example, in heart failure patients. So that would be a second point to add to the steps towards causality. The third one would be what also the presenter astutely showed. biologic plausibility. That means essentially there is a mechanism that leads to that direction, and that was also described. So we have the mechanism, the the biology. That means biologically plausible association. So we put all of these things together, and then the fourth one would be consistency of the data. If people in different populations in the U.S., in non-NHANES and other populations in South America, in North, everywhere else in China, they find the same thing, and that's a consistency of the association. And then finally, using and exhausting different models, as also Dr. Sempus astutely discussed. That means sensitivity analysis. Yet, having said all of these things, it's very difficult to make any causality inference given the data being associative, and at the same time not being convinced about some of the steps towards causality, such as having dose response phenomenon or gradients and other things. So for now, we have no choice but to mark this as association, despite the fact that it is biologically relevant and there are similarities across other populations and other disease states. Thank you.
Thank you very much for that. There's a difference. There's actually no difference in the fatal cardiovascular or cancer deaths. There's a large number of death causes that were not reported. I'm not familiar with the structure of the NHANES registry, but is that something that is feasible to kind of fish out why that whole chunk of people died? Maybe there's a signal in the cause of death, which can help us tease out whether caffeine was helping in one way or the other. Dr. Vieira, what's your views on that?
So that's an important point, and NHANES has information about many different variables, and then to evaluate outcomes, NHANES dataset is linked to another dataset which is called the National Death Index, and that has information regarding mortality. So it should be noted that from the more than 1,200 participants that died in this study, 368 deaths were due to cardiovascular events and 226 deaths were due to cancer. Thus, almost half of the deaths were due to other causes and not to cardiovascular or cancer. So National Death Index database also includes other mortality categories such as infection, accidents, COPD, mental illnesses, or other chronic diseases. And almost half of the mortality was not due to cardiovascular diseases or cancer. And that was an intriguing fact that we also tried to come up with an explanation, but it was not easy for us.
Thank you. Dr. Geddes, we're nephrologists, so there's a lot of questions coming up on our chat channel, which are looking at trying to tease out a mechanistic approach to this protective benefit, if there is a signal there. So as a nephrologist, would you look at blood pressure control, urine sodium excretion, sodium balance, et cetera, et cetera? How would you want to channel this if we are trying to look at some causal benefit?
Yeah, that's a difficult one. I'm not sure. Of course, the majority of these patients are patients we don't see as nephrologists. They had very, very mild renal abnormalities. And I've always thought it seems intuitively wrong that a drug that causes tachycardia should be protective somehow. I'm relieved that it is as a fan of coffee, but I don't understand how caffeine is protective.
Dr. Vieira, any thoughts on that?
I think you raised an important question, but the truth is that not only in this study, but also in the general population, and although caffeine causes tachycardia, the tendency that has been found is towards protective effect. That's the only thing I have to say, but please add something, I don't know.
So this is Ali. Maybe just to this point to say, I think the bioplausibility of the theory that coffee could be cardioprotective, or even some hypotheses of it being protective against tumors and cancers. It didn't show that. So in your study, correct, like the cardiovascular mortality was not affected, cancer mortality was not affected. So one would go then to question this physiological theory, the construct that coffee would be protective through that. And then the other question one could point out is perhaps if that is due to a confounder. We see these associations with better mortality, all-cause mortality. The question is, if indeed those people who are better off surviving would not drink coffee, would they have had even a better survival benefit with this regard? We don't know. Is there a way to look into that? You know, how would we know that they may even not do better if they wouldn't drink coffee? They are affluent, they are from better subgroups with regards to what we know to be associated with overall survivals and health benefits.
So you have the problem, as with all secondary data analysis evaluating nutritional variables, there is a lot of confounding, and it's not a prospective study. And even in prospective studies, when you evaluate nutritional interventions, it's really hard to make sure that people adhere strictly to the recommendations. So there is always confounding, and you try to reduce confounding by performing adjusted models. But at the end of the day, of course, it's a secondary data analysis.
Can I add, I suppose what we're saying is, are we confident enough in this association to proceed to randomized controlled trials? Would people be willing to randomize patients to caffeine or not caffeine, presumably in a pill format? And I'm not sure that we're there yet, but I'd be interested to hear what other people think.
Well, I think that would be really interesting. Not similar because they were not using caffeine, but also nutritional interventions have been already performed mostly in patients with diabetes. That's an area where nutritional interventions have been performed on randomized controlled trials. So it has been done before. And I don't know if there will ever exist a study evaluating the effect of caffeine on mortality, a prospective study, but I think I would love to hear the results.
Right, I think we're getting close to the end of the hour. Are there any other questions?
Can I ask that, Dr. Vieira, so what do you think all those patients died of? Do you think it's just a classification problem and they actually were cardiovascular deaths?
My bet would be that it would be a classification problem, and if they died of other causes, I also don't know which causes they were, but that was the data that we have from Anne Haynes.
So there's this question from on our chat channel from Dr. Ganesh Deva. Would you tell patients to drink more caffeine, or just tell them that caffeine doesn't seem to be dangerous? Or can we even answer that question at this point?
Well, I would, people can have different opinions, but I would just tell them that caffeine doesn't seem to be dangerous, as this is an observational study. And I think it's important to have that in mind.
Dr. Geddes, what would you tell your patient?
I would say we don't know yet. Just like I used to say about water until we got the randomized control trial last year that showed us that drinking extra water doesn't reduce your risk of progression of chronic kidney disease.
I think Dr. Kalantazade is trying to say something. Dr. Kalantazade?
Yeah, probably I would tell my patients that if they ask that right now we don't know, but at least some studies have shown that there is no high risk. If anything, there may be some protection, because my patients always ask me, so what about tea and coffee? Should I stop it? And I tell them that the data generally are supportive. So if anything, and if you enjoy coffee, please go ahead and continue to have coffee as long as you don't have contraindications such as atrial fibrillation or cardiac issues.
All right, that sounds reasonable. I think we'll let that be the last word. If there are no other, if there's no other questions, let me just check the chat channel. We don't have. So, Dr. Stompas, thank you very much for your presentation, and thank you to our panelists, Dr. Vieira, Dr. Geddes, and Dr. Kalantazade. With that, our session comes to an end today. Thank you very much, everybody.
Thank you.